Hi, my name is Liliana Ruiz, and today we have here Mr. Quinn, which is a 58-year-old male, presenting to the clinic with complaints of confusion that seem to be getting worse as time progresses. Patient states he feels like he can't focus and has difficulty understanding what people are saying to him. Patient communicates with frustration as he states his mind feels really foggy, disorienting, and is concerning and him and his family. Also states he feels like he is in a dream. States he has been experiencing urinary retention, frequency, nocturia, denies any alleviating or aggravating factors at the moment, denies any related or past illnesses, no past surgeries or past diagnostic testing related to present illness. Patient takes atenolol 50 milligrams PO daily. He has not taken it today. No known allergies. Medical history of hypertension, family medical history of mother has hypertension and father has type 1 diabetes. As far as social history, patient occupation, he owns a hardware store and he works 50 hours a week. States he lives with his wife, denies smoking, denies drug substance use, does endorse drinking alcohol few beers a few times a week with dinner, denies any safety issues at the moment, denies any psychiatric history, no suicidal or homicidal ideation, is alert and oriented ×4, denies any syncopal episodes, seizure history, weakness, paresthesia, or blackout spells, denies any skin, GI, or auditory issues, denies denies blurry vision or visual changes of any kind, does use glasses for nearsightedness, denies any musculoskeletal issues, does not use any assistive devices, no recent weight change, fevers, chills, or night sweats. Patient admits to changes in energy level that started 2 weeks ago. Denies any chest pain, palpitations. Stacy has noticed edema in legs and feet that started 2 weeks ago. As far as respiratory, patient endorses shortness of breath that started 4 to 5 days ago that occurs when using stairs. Denies wheezing, hemoptysis, history of pneumonia or TB. Patient denies any bleeding disorders, no bruising, blood transfusion history, denies swollen glands, increased thirst, increased hunger, or cold or heat intolerances. As far as genitourinary, patient does admit to urinary symptoms such as urinary retention with only urinating small amounts in frequency, about 10 to 12 times daily. States urine's color is yellow and clear, no abnormalities. Patient's blood pressure is 150/70, temperature is 37.1 Celsius, BMI is 31.7, pulse is 80, respiration is 16, and oxygen is 98% on room air. Patient's overall appearance is healthy with no acute distress, alert and oriented ×4, answers questions appropriately, is able to follow commands with no problems, able to communicate to provider with chief complaint, home medication, and medical history with no difficulty. Skin is white, warm, dry, and intact, no rashes or lesions noted. Head, eyes, and ears are all within normal limits. No nose, neck, or throat abnormalities noted. Cardiovascular S1 and S2 are regular rate and in rhythm. No extra sounds, clicks, rubs, or murmurs on auscultation. Capillary refills are less than 2 seconds. Pulse is 3+ throughout. Respiratory and no edema noted. Respiratory is symmetrical chest wall expansion, regular rate, non-labored breath respirations. Lungs are clear to auscultation on all 4 fields. As far as gastrointestinal, patient's abdomen is obese. Bowel sounds are normal, active on all 4 quadrants. Abdomen is soft, non-distended, denies tenderness or discomfort, no hepatomegaly, no CVA tenderness. As far as genitourinary, patient's bladder is non-distended, no CVA tenderness noted, no masses, lesions, no hernias or genital discomfort, discharge, or lesions noted. Musculoskeletal is intact. Patient it has a normal, full range of motion, is able to ambulate with no difficulty. Speech is clear, good tone and posture, erect. Tandem gait is normal. DTRs are 2+. Cranial nerves, 2 to 12, are intact. In psychiatric history, like I said, he denies any suicidal or homicidal ideation, is alert and oriented, appears well nourished, normal mood, maintains eye contact, and answers questions appropriately. As far as lab testing, albumin 24-hour urine, it was negative. CBC, WBCs were 13.5, MCV 72, CMP was creatinine 3.2 and bilirubin of 3. And then the UA did show a WBC trace, protein trace, and then WBCs being at 3.5, RBCs at 3, and CAS few, and bacteria few. My primary diagnosis would be a urinary tract infection, as the patient presents to the clinic with symptoms of urinary frequency and urgency, which he only urinates very little, and which might signify retention, and then he states he feels confusion. The diagnostic test did demonstrate few bacteria elevation on creatinine and WBCs, which all of these diagnostics may demonstrate that this may be occurring at the patient's cellular level. Additionally, there is also protein trace and elevation in creatinine, which can occur during urinary tract infections due to the inflammation in the bladder caused by the infection and the increase in white blood count. The second differential diagnosis would be benign prostatic hyperplasia, which the patient does express a concern with urinary frequency, nocturia, and when he urinates, it is very small amounts. These symptoms can be a sign of BPH. BPH is known to be causing men bladder obstruction, which can lead to cell proliferation growth in prostate transition zone, thus causing outcomes such as urethral compression, which in turn obstructs the bladder, causing urinary retention, which can lead to infections and incomplete bladder emptying. And then lastly, glomerulonephritis would be the third differential diagnosis, which the patient is expressing nocturia. And even though not seen on the cardiovascular physical assessment in this patient scenario, the patient did express he has noticed swelling in his lower extremities as of lately. The patient also stated he has been feeling weak, fatigue, and poor appetite, as evidenced by patient's lab results, where there was a proteinuria and elevated creatinine level. Moreover, due to the damage in the glomeruli, the kidneys are unable to filter the blood properly, thus resulting in protein in the urine, which is evident in this scenario. As far as medications, the medications that I would prescribe for this patient would be antibiotic treatment. I would prescribe Bactrim, 800 milligrams and 160 milligrams every 12 hours for 10 days. Non-pharmacological treatments that I would prescribe for this patient would be to drink plenty of fluids, as this can help with flushing out the infection and hydrating the kidneys. And then as far as culture consideration goes, I would take into consideration that the patient does work many hours per week, and encourage the patient, as far as he has very good work ethic, to make sure that he is urinating as appropriate as needed during work, and not retaining, as this could make it the symptoms worse. As far as health promotion, I would provide the patient with dietary guidelines for alcohol, which he does endorse the drinking, and symptom management education, which it would be good hydration, and then and if he is experiencing any side effects due to antibiotic use, such as diarrhea or abdominal pain, to please reach out to us to ensure that he is still taking the medication and it's not leading to medication non-compliance, which can result in antibiotic resistance. As far as referrals, I would not be referring the patient at the moment, unless the urinary tract infection becomes very complicated. Then I would possibly involve infectious disease. And then as far as follow-up, I would encourage the patient to follow up at the clinic after they have completed the antibiotic dose to repeat a urinalysis, CBC CMP to ensure that the WBCs have gone down, and then his kidney function is back to within normal limits.